Hello, and welcome to my series on the CT of thoracoabdominal emergencies. I'm Dr. Benjamin Strong, the Chief Medical Officer of Virtual Radiologic, or vRad. I started my career with an internal medicine residency and followed that with 3 years of work as an emergency physician. I then returned to training for a radiology residency and a fellowship in body and MSK MRI. In the course of my over 20 years in radiology, I have worked as a private practice radiologist, an academic radiologist, and for the last 17 years as a teleradiologist for vRad. I have been the chief medical officer there for 8 years and am licensed to practice in all 50 states. Here is our agenda for this series, which I have broken into 9 sessions of 8 cases each, all grouped by organ system. Session 7, Hepatic Emergencies. We'll start with a case of alcoholic hepatitis. Appreciating alcoholic hepatitis is really a matter of appreciating the extent of 2 nonspecific findings. So extensive fatty infiltration throughout the entire liver and massive hepatomegaly. In addition, frequently there will be at least a little perihepatic fluid present as well. So when you see such fatty infiltration, such enlargement of the liver as this, and a touch of intraperitoneal fluid on top of it all, you can pretty confidently say this is likely alcoholic hepatitis. Note all the fluid in the abdomen is actually difficult to distinguish from the fatty infiltrated and very hypodense liver, but you can see it here posteriorly especially, easily appreciated when you know it's there. So this is a diagnosis you can at least suspect on these non-specific imaging criteria. Typically, you can get lab confirmation pretty easily in that the AST will be higher than the ALT. So that is a case of alcoholic hepatitis. Our next case is a case of hepatic abscesses with portal venous thrombosis. There are numerous small hypodense lesions all throughout the liver. Note also the variegation in contrast enhancement, suggesting abnormalities in portal venous flow. More of the same here, these small hypodensities consistent with abscesses. These bacterial abscesses are frequently these small and multiloculated such as this. They give the impression of hydatid disease in many cases, but of course that's much less common than just standard bowel flora. Note also on this particular cut, you can see a posterior filling defect within the portal vein itself, giving you some idea as to the origins of these hepatic infections. Lower down, you can appreciate the diverticula of the sigmoid colon and some chronic appearing wall thickening consistent with diverticulitis. Here on the cine, again, you can appreciate all those small hypodensities. Look at all the extensive portal venous filling defects, though. They're really emanating out from that central defect in almost all directions. And then down in the pelvis, again, the chronic appearing diverticular changes. So there are the abscesses. Note all the extensive portal venous thrombosis, and again, the variegated contrast enhancement of the liver parenchyma. And here it is on the coronal, really allowing you to see those portal venous branches, all thrombosed and hypodense, and you can better appreciate that main portal venous filling defect as well. So that is a case of hepatic microabscesses in the setting of septic portal venous thrombosis. Our next case is a Fitzhugh Syndrome. This is usually a gynecological infection that causes extensive peritonitis. And you can see that here with this peripheral hepatic enhancement. Quite an unusual appearance that actually disappeared on delayed images. So this was visible only on this earlier phase image. There is endocervical enhancement and cervical hypodensity. I'm not sure if this is to the extent that it could have been called in isolation. However, it certainly was consistent with this patient's symptoms, and the ultimate infectious agent was gynecologic. So there is that peripheral enhancement really throughout the entirety of the liver, certainly that portion of the liver exposed to the peritoneum. And then again, a rather plump cervix with endocervical enhancement. So that is a case of Fitzhugh-Curtis syndrome, peritonitis arising from a gynecologic infection. Our next case is an acute presentation of Chiari Syndrome. Of course, there are acute and chronic presentations, and they do have different appearances on CT. You can appreciate the heterogeneous enhancement throughout the liver parenchyma. Also note the enlargement and hypodensity of the IVC and the confluence of the hepatic veins right at this level. That in this later phase of contrast enhancement certainly is consistent with thrombosis and occlusion. Lower down, you can see again the variation in hepatic parenchymal enhancement. Note also gallbladder wall thickening, a finding that it does frequently accompany this diagnosis. We'll also be able to appreciate the IVC here. So watch as it goes from occluded to patent at this lower level, the infrahepatic cava. And then occlusion again with all kinds of thrombosis here of the hepatic veins and of the IVC as well. Appreciate again the variation in hepatic parenchymal enhancement and that gallbladder wall thickening. Even get the sense of webs and perhaps some clot organization in that infrahepatic IVC. There. All right. So that is a case of acute Chiari syndrome. Our next case is a chronic passive congestion, the hepatic complications of chronic congestive heart failure. So, of course, there is significant cardiomegaly, and you can even see evidence of a valve replacement, suggesting the ultimate origins of that problem. Markedly heterogeneous parenchymal enhancement in a classic nutmeg appearance, pretty much diagnostic of chronic passive congestion. Note also the marked distension of the hepatic veins and the IVC, although in this case they are enhancing at least slightly. There again the cardiomegaly, marked dilation of the IVC and hepatic veins, and of course extensive parenchymal contrast abnormalities. We'll look at that one more time. In the dilated IVC and hepatic veins, and then the markedly heterogeneous parenchymal enhancement. So that is a case of chronic passive congestion. Our next case is a hepatic artery aneurysm with acute rupture. So here is the aneurysm here, high in the portal region, a well-circumscribed contrast collection with a tiny focus of extravasation anteriorly. On the cine, you'll be able to appreciate fluid all throughout the portal region as a result of that. Hepatic artery aneurysms can be very tricky. They can present with hyperbilirubinemia due to their location in the porta, and they typically are small and difficult to identify. They're not common enough to be on everyone's routine search pattern. So I've seen a number of these go undiagnosed. Obviously, in this case with acute rupture, it's a somewhat more straightforward diagnosis. So here you'll see there's the hepatic artery aneurysm with extravasation. There it is as part of the course of the vessel. Better appreciated here. You can see it coming from the celiac trunk. So there it is again, high in the porta with focal extravasation. And of course you can trace that vessel origin back to the celiac trunk, verifying its identity. All right, that is a case of a hepatic artery aneurysm with rupture. Our next case is a Miroti Syndrome. That, of course, is a gallstone lodged in the cystic duct, but which causes obstruction of the common duct. And here you can see evidence of that manifesting as extensive bile duct dilation emanating from the portal region. Lower down, there is cholelithiasis. There is an adjacent liver hypodensity next to the gallbladder fundus, which ultimately was found to be a small liver abscess. Here is where you can truly appreciate a cystic duct stone causing common bile duct dilation. You can see the dilated common bile duct here above the stone, and that stone has a thin, soft tissue wall surrounding it, especially on its superior aspect. That's what tells you it is still within the cystic duct. Of course, we can better appreciate this on cine. There are the dilated biliary ducts. Now we can trace those down to the point of obstruction, the cystic duct stone, beyond which the common bile duct is decompressed and normal in size. Let's look at that one more time. Dilated ducts. Now we'll track the common bile duct proximally to the level of the cystic duct stone and then see its decompressed distal portion. And we've got the coronal on that as well, where you can really appreciate that cystic duct wall lying on the superior aspect of the obstructing stone and the distal decompressed duct. There it is. That's the key image, I think, that really shows you that obstructing stone remains within the cystic duct. So that is a case of Miroti Syndrome. Our last case in this session is gallstone emphysematous pancreatitis. More superiorly, you can see collections of gas and fluid in the pancreas, which even on this non-contrast scan allow you to confidently diagnose necrotic pancreatitis. In addition, you'll note throughout the scan there are multiple portal venous and superior mesenteric venous gas collections resulting from this necrosis. More inferiorly, there you can see the superior mesenteric venous gas and of course more pancreatic stranding and fluid, which persists even at this lower level. But on this lower level you can appreciate the source of all the problems. Fortunately, a non-contrast scan without oral or IV allows you to confidently diagnose this distal ductal stone right here wedged in the ampulla. Throughout all of these images, you'll be able to appreciate the dilated common duct in spite of all this non-contrast chaos you see. So here we'll appreciate the retroperitoneal gas collections and extensive pancreatic stranding and fluid. Also note that superior mesenteric venous gas. And now you can pick up that dilated distal common duct extending inferiorly to the point of obstruction. And so that is a gallstone pancreatitis resulting in severe necrotic emphysematous pancreatitis. And that concludes session 7. Thanks very much for watching.